Thank you for that kind introduction. My name is Cole. I'm a PGY2 emergency medicine resident at University of Arizona, and today we'll be talking about treating epistaxis. Our learning objective today is to discuss therapies for treatment of epistaxis with a focus on vasoconstrictors. There are several common causes of epistaxis or nosebleed, the etiology of which are listed here. Epistaxis digitorum, um, as demonstrated by the picture, is definitely one of the most common in the pediatric ambulatory population, as seen here. And of course, epistaxis is divided into two categories based on where the bleed occurs. So we have anterior, which accounts for 90% of the epistaxis episodes, and they generally come from the Kieselbach's plexus. We see here we have a nasal clamp clamping my Kieselbach's plexus, and this is a good little pro tip here. If you ever run out of nasal clamps, you can just tightly bind two tongue depressors together. You have your nasal clamp. The posterior nosebleeds are more difficult to treat and may necessitate an ENT consultation or admission. So therapies for epistaxis, obviously we want to address the underlying cause. We have vasoconstrictors, topical hemostatic agents, chemical cautery, nasal packing, and I don't want to steal any thunder from a future pearl, but plasminogen activation inhibitors. So today we'll focus on the topical vasoconstrictors. Mechanism of action is alpha-adrenergic stimulation, which results in constriction of the blood vessels and generally less blood flow to that area, giving it a little more time to heal. We have listed here the common medications used in our emergency department, and comparative effectiveness studies between these agents are lacking currently. It's very important to note that there are different concentrations of cocaine, and you want to know if you have the 4% or 10% stocked in your Pyxis. The pros of cocaine: it's a potent anesthetic and vasoconstrictor, very quick on, very quick off, it's effective. Some of the cons: it is a Schedule II medication with some potential for abuse and misuse. The cost has risen in recent years, and there are some untoward cardiovascular effects we'd want to watch out for. Also, the dose of cocaine is not well alliterated to use in this situation. When you look at the package insert, it doesn't mention a dose. Just says choose the lowest effective dose. So that wasn't much help. And when we were doing this on a particular patient, we looked up and we saw one of our trial graphics that says 1 to 3 mg per kg, and we had a 160 milligram bottle of cocaine, and we had an 80 kilogram patient. So we thought, well, 1 to 3, we're landing right pretty much at 2. So normally we like to start low, go slow, but we didn't really want to get on some sort of Pyxis list for wasting half a bottle of cocaine. So we thought, hey, diddle diddle, let's start somewhere in the middle. The patient, of course, perhaps would have preferred us to start low and go slow, as their blood pressure and heart rate did rise pretty appreciably over a short period of time after administration of the cocaine. However, we did have the fringe benefit of improved mood and a feeling of euphoria. We determined this through some of our patient interview and the subsequent quotes from that, which included, "Ooh-wee, this takes me back to the 70s, and I'm feeling good like James Brown." Regardless of those great things, the epistaxis episode did resolve, and the untoward effects of cocaine also resolved shortly thereafter. I'd be remiss if I did a presentation without mentioning HCAP scores, and the patient summed it up best. I think we got a 100% on this one. The next time I come back here, I'm asking for the pharmacist. So our key takeaway points here: topical vasoconstrictors are an excellent non-invasive pharmacotherapy option. We'd recommend the lower end of this 1 to 3 mg per kg range, and there are lots of different approaches to treat this, plenty of protocols, expert opinion. I'd be happy to share that with anyone. I came across quite a bit of it in preparing for this talk. My references, and I don't want to run the red light standing next to me, so have a good day. That's my Pearl.